We will do a image study today. Very simple, very commonly asked in the Viva, Oxy, MCQs also they may be asked. What this image is, look at that. Look at that. Look at that. Here X-ray is there, pelvis is seen, and vertebra seen. Both stents are there. So it is plain X-ray KUB showing right sided trigon calculus. You can see here trigon calculus with both J stent here coming from the kidney, pelvis to the bladder. So plain X-ray KUB is means it is below the diaphragm level. Entire lumbar vertebra, sacral vertebra have to be seen. Entire pelvis should be seen. It is mainly concentrating on the kidney, ureter and bladder area. This area, kidney shadow is seen because of the density difference between the perinephric fat and kidney. So proper bowel preparation is should be done. Otherwise, bowel gas will interfere with the proper kidney shadow. But this kidney shadow will not be there in the children because perinephric fat is not formed well, or xerota is not formed well. And line of ureter is along the transverse foliage of L2, 3, 4, 5 like that. And near the ischial spine it immediately runs into the bladder. So a line of ureter you have to mark for any radiopaque shadow. That means there will be ureteric stone. And any radiopaque shadow in the kidney region and pelvis regions suggests that it is a renal stone, because most of the renal stones are radiopaque, 80 to 90%. Reverse is for the gallbladder stone. 80 to 90% of the gallstones are radiolucent. 80 to 90% of the renal stones are radiopaque. So there is how this patient, you can see that already there is a both side J stent is there in the ureter. That means patient had obstruction, patient had obstructive uropathy. That means creatinine might have been high. That's why ureter stent are placed, J stent are placed into the ureter. Now you got a large stone that is trigon calculus. You can see that, see the stone, trigon calculus is there in the right side. So that should be treated by PCNL, percutaneous nephrolithotomy. Of course, you have to do urine culture. You have to start antibiotic. Both sepsis is very common. Sepsis, septicemia, may lead to the high mortality. All those things should be taken care of. Of course, you have to do a CT KUB. Not just plain X-ray KUB is not sufficient. You have to do a KUB CT to identify and see properly, evaluate properly. It's a must, often a dynamic one also. And PCNL is the treatment, and of course, usually treated by urologist as such. So remember between the difference between the plain X-ray KUB. Plain X-ray KUB is enter this area seen, and it is high penetration X-ray because you have to concentrate on the retroperitoneum. And usually plain X-ray KUB is red, first bony part from the below upward, pelvis part, sacrum. Then count the lumbar vertebra from below upward, never from above downward, L5, 4, 3, T1. Then kidney shadow, then line of ureter, then bladder area, then urethra area. So from below upward, then above down. That's how exactly you'll read plain X-ray KUB. Plain X-ray abdomen is different, where diaphragm should be seen. It's the lower chest and abdomen. Lower pelvis need not be seen. So diaphragm is a contrast, should be seen. It is mainly done for the gastrointestinal diaphragm and perforations to see the perforation and multiple air fluid levels in case of internal obstruction, or otherwise to assess the acute abdomen. So there's a difference where penetration is less because you are concentrating on the abdominal organs, so not on the retroperitoneum, like in what you are doing, taking X-rays in plain X-ray KUB. That's the difference you should remember. So diaphragm should be seen to say the given X-ray is plain X-ray abdomen, unlike in plain X-ray KUB. So answer the MCQ, students. Urinary bladder calculus predisposed to what? Transitional cell carcinoma, adenocarcinoma, squamous cell carcinoma, small cell bladder cancer. So find out the answer, put it on the comment. Tomorrow we'll discuss and tell the answer, what's the right answer and why. So go through my clinical methods in surgery and manual of surgery, operative surgery, and tissue approximation with the video lecture, how to do that, and my digital video lecture through JP. In detail, everything covers for UG and basic for PGs. And so please always purchase that one for a year so that you can learn everything, basic especially. And so you have understood this lecture very well, students. Thank you very much.